Welcome to This Explainer. Today we're unpacking what is honestly one of the most massive, high-stakes medical puzzles out there: how doctors actually go about diagnosing and managing neurocognitive disorders. You know, when someone's memory or their ability to think clearly starts to decline, the stakes are just incredibly high for everyone involved. And the list of potential suspects is really long. But understanding this process, it isn't just for doctors. Getting a handle on this helps all of us advocate for our aging family members, and it gives us a real appreciation for the fascinating detective work of medicine. So let's dive right into the step-by-step clinical roadmap that the experts use. Okay, let's start by establishing our baseline definition straight from the DSM-5, which is essentially the standard psychiatric rulebook. Now, the absolute most crucial word for us to focus on here is acquired. We're talking about structural or functional brain disturbances that cause a very real, measurable decline in a person's memory, abstract thinking, or judgment. Because these are acquired conditions, it means they represent a clear decline from a level of functioning the person had previously attained. So we're not talking about developmental issues that were present from birth. This is a change from their baseline. Here is our agenda for today, which basically acts as our diagnostic funnel. We'll be moving step by step through acute delirium, amnestic disorders, functional and reversible causes, true dementias, and finally, targeted management. Let's look at step 1, the provisional diagnostic funnel, a step-by-step clinical roadmap. When a patient presents with cognitive impairment, their symptoms often heavily overlap, so doctors use what's called a provisional diagnostic funnel. Think of it like a mental checklist of elimination. Step 1 is looking for acute clouding of consciousness. Is the patient suddenly confused right now? If yes, that points directly to delirium. If not, we move to step 2. Is it just an episodic memory issue? If it's isolated to that, we're looking at an amnestic syndrome. Then we check step 3. Could this be a functional mimic, something like severe depression? Only after systematically ruling all of those other things out do we finally arrive at step 4, which is diagnosing true dementia. It's a brilliant process of elimination. Moving to step 1, delirium, identifying a medical emergency. So why is delirium the very first thing we check for in that funnel? Well, because it hits fast and it hits hard. Notice the really striking contrast on this slide. Delirium has a sudden, acute onset, and it fluctuates wildly. A patient might actually seem totally fine and lucid one moment and then highly confused or agitated the next. It also often gets way worse at night, which is a phenomenon known as sundowning. Now compare that to dementia. Dementia is insidious. It creeps in slowly, over a long period of time, progressively deteriorating without those rapid, chaotic swings. It primarily impacts short-term memory before it eventually starts affecting global attention. Missing a delirium diagnosis is incredibly dangerous. To put it into perspective, the mortality rate for delirium can reach a staggering 50% within just one single year. 50%. It's prevalent, and the stakes are quite literally life and death. And you might be wondering, what actually triggers it? Well, very often, it's the hospital environment itself. Polypharmacy, which means being on way too many intersecting medications, is a massive culprit. But it can also be triggered by things that seem relatively simple, like dehydration, severe sleep deprivation, or even a hidden underlying infection. So how do we handle this? The crucial point for management is simple in theory, but tough in practice. You have to play detective, find that underlying cause, and treat it immediately. You're checking vital signs, running blood glucose tests, looking for any sign of infection. But equally important is prevention and managing the patient's environment. Medical teams use frameworks like the Hospital Elder Life Program, or HELP, to actively target risk factors. You want to reorient the patient frequently, literally putting clocks and calendars right where they can see them, ensuring they're in a quiet room, and making sure there's sufficient lighting so they aren't disoriented by shadows. If severe agitation occurs and the patient is a danger to themselves, very low-dose antipsychotics like haloperidol are sometimes used as a first line. But I can't stress this enough. They have to be managed with extreme care. Now for step 2, amnestic disorders, when only memory is affected. If a patient's overall alertness is normal, we bypass delirium and move down our funnel to amnestic disorders. This is where episodic memory, meaning both the ability to form brand new memories and retrieve old ones, is persistently affected, but other cognitive functions might be fine. A really classic example of this is Wernicke-Korsakoff syndrome. Here's how it builds. Severe malnutrition, or very commonly severe alcohol misuse, leads to a significant vitamin B1 deficiency, also known as thiamine. This lack of B1 triggers Wernicke encephalopathy, causing profound confusion and ataxia, which is a loss of body control and muscle coordination. If that goes untreated, it progresses into Korsakoff syndrome. In this stage, patients suffer from massive memory gaps, and their brains try to compensate by unconsciously fabricating stories to fill in the missing pieces. It's a fascinating, albeit tragic, symptom called confabulation. They aren't lying on purpose. Their brain is just trying to make sense of the gaps. If you are ever looking at this specific clinical presentation, especially in a patient who has a known history of alcohol misuse, you absolutely must assume it is Korsakoff syndrome and treat it as a medical emergency. The immediate management step here is urgent parenteral, meaning intravenous or injected, vitamin B1, combined right away with rehydration and nutritional support. Moving on to step 3, functional and reversible causes, ruling out mimics. Okay, before anyone gets labeled with irreversible chronic dementia, we have to keep our detective hats on and aggressively hunt for systemic culprits that completely mimic it. Take a look at this table. We categorize these potential mimics to make sure we don't miss anything. We look for intracranial issues, like a subdural hematoma pressing on the brain. We check the endocrine system for things like hypothyroidism or Addison's disease. We run metabolic panels to rule out uremia, which is essentially the effects of kidney failure or hypoglycemia. And of course, we rigorously screen for toxins and drugs. This includes everything from alcohol misuse and opiates to heavy metals and even common anticholinergic medications. The amazing thing here is that fixing these underlying systemic issues can actually reverse the cognitive decline entirely. And we definitely can't talk about mimics without discussing the psychiatric ones. Severe depression, for instance, can cause a condition we call pseudodementia. And notice the really striking behavioral contrast here on the slide. In depressive pseudodementia, the onset is noticeably more acute. The family is usually very aware that something is wrong because the patient often complains loudly about their cognitive loss. They highlight their own failures, and when you ask them a question, they frequently just give up and say, "I don't know." True dementia looks totally different. The onset is incredibly insidious. Families are often totally unaware in the early stages because the patient actively struggles to hide their decline. They make a real effort to perform tasks, and instead of just giving up with an "I don't know," they'll often offer near-miss answers, genuinely trying their hardest to mask the deficit. Which brings us to step 4, true dementia subtypes, navigating chronic cognitive decline. Once we've successfully rolled out delirium, memory-only disorders, and all those reversible mimics we just talked about, we finally enter the really complex landscape of primary neurodegenerative dementias. These are characterized by an acquired, gradual, and global impairment of intellect and memory. As this chart clearly shows, Alzheimer's disease is by far the dominant subtype, making up about 75% of all cases. Vascular dementia is the next most common at around 15%, and the remaining 10% is made up of a mix of distinct, much rarer subtypes like Lewy body, frontotemporal, and prion diseases. Let's start with the big one, Alzheimer's. Physically, in the brain, we see structural changes like neurofibrillary tangles, amyloid plaques, and a significant loss of cholinergic neurons, which are the cells absolutely vital for processing memory. But clinically, doctors are watching for these hallmark symptoms, often called the 5 A's. First is amnesia, which typically destroys new, anterograde memories before it starts wiping out older, retrograde ones. Then there's aphasia, which is impaired language function. Next is apraxia, the inability to execute complex motor planning. Then we have agnosia. Imagine holding a totally familiar object, like a hairbrush, and your brain just failing to recognize what it is. And finally, anomia, which is that incredibly frustrating struggle to retrieve the names of things or people. Diagnosing the exact subtype beyond Alzheimer's is absolutely crucial because it essentially dictates the patient's entire future. Let's look at the distinctive features. Vascular dementia typically presents with what we call a stepwise deterioration. Instead of a smooth decline, you see sudden drops in function, and that's because it's caused by multiple small infarctions or mini-strokes in the brain. Lewy body dementia is a really challenging one. You can expect a waxing and waning presentation, highly characteristic early visual hallucinations, and then the onset of Parkinsonism symptoms later on. Frontotemporal dementia is unique because it often presents first with profound changes in personality and behavior. We're talking severe apathy or intense disinhibition, rather than just memory loss. And finally, prion diseases like Creutzfeldt-Jakob disease show a terrifyingly rapid progression. We're talking severe psychiatric and motor symptoms developing over mere months, usually resulting in death within just 1 to 2 years. So what do we do about all this? While many primary dementias are progressive and currently irreversible, our management is highly structured to compassionately maximize the patient's quality of life. We start by aggressively controlling risk factors like hypertension and diabetes to prevent any further deterioration. This is especially important in vascular dementia cases. Pharmacologically, we use anti-dementia medications, specifically cholinesterase inhibitors and memantine, which can actually help slow down the memory loss. But management goes way beyond just pills. We heavily utilize psychosocial adaptations. This means providing a highly structured, constantly reorienting environment to maximize whatever intact functioning the patient still has. And for those really distressing behavioral symptoms that can arise, doctors might carefully introduce SSRIs or highly targeted antipsychotics to provide relief. Finally, let's look at step 5, specific geriatric diseases, the cognitive impacts of movement disorders. These specific conditions perfectly illustrate the intense overlap between neurology and psychiatry. In Parkinson's disease, for example, patients very often develop a dysexecutive syndrome, meaning they heavily struggle with planning, focus, and organization, and they can also develop psychosis. If that psychosis occurs, it requires highly specific management, very often utilizing low-dose quetiapine. Then there's Huntington's disease. What's wild here is that severe behavioral and cognitive changes, like intense depression or irritability, can actually show up and precede the classic physical motor signs by up to 15 years. And then we have normal pressure hydrocephalus, or NPH. This presents with a highly specific, potentially reversible trilogy of symptoms: gait apraxia, urinary incontinence, and dementia. Recognizing that exact trilogy is massive because it allows doctors to intervene surgically with a ventricular shunt and potentially reverse the cognitive symptoms entirely. Which leaves us with a really profound question as we wrap up this explainer today. Think about it. If cognitive and behavioral changes in diseases like Huntington's can silently precede the physical motor signs by up to 15 years, how might early detection entirely reshape the future of aging and neurocognitive management? As our diagnostic tools get sharper and more advanced, we might one day be able to intervene decades before the structural damage to the brain becomes irreversible. It completely changes how we view the aging brain and the timeline of these diseases. Thank you so much for joining me on this explainer. It's a heavy topic, but an incredibly important one. I'll see you in the next one.